Welcome back to LipidCurious, the podcast dedicated to demystifying lipids for medical boards and real-world clinical practice. I'm your host, Dr. Vishnupriya Pulipati, a board-certified endocrinologist and lipidologist. This is Season 1, Episode 4, Cholesterol. Here's what we'll unpack today. 1. The cholesterol paradox, why it's both essential and dangerous. 2. How cholesterol is carried and measured in blood. 3. LDL-C in clinical practice. We're going to discuss targets, percentage reduction, and how low is too low. Before we start, I want to say a big thank you. The encouragement and feedback I have received from friends, colleagues, mentors, and listeners has been incredible. And it's what gives me the confidence to keep building this space. This episode comes with a bonus visual handout in the show notes. I have attached images to earlier episodes too. For the complete set, visit www.lipidcurious.com. Special thanks to Dr. Thomas Dayspring, whose work inspired many of the visuals. And yes, I may have borrowed my toddler's coloring pens for this masterpiece, so please be kind with your art critiques. Quick reminder, this podcast is for educational purposes only, not medical advice. All right, let's get into it. Cholesterol is not the villain it is made out to be. We literally cannot survive without it. Every cell membrane relies on cholesterol for structure and stability. It's also the backbone for steroid hormones and the starting point for vitamin D and bile acids. Cholesterol is a type of a sterol predominantly found in animals. Structurally, it has 4 fused hydrocarbon rings plus a hydroxyl group and a short hydrocarbon tail. Our dependence on cholesterol is so deep that the liver makes 80% of the cholesterol. Only 20% comes from diet. The same molecule that sustains life can also drive atherosclerosis, especially when it ends up in the wrong place in the wrong lipoproteins. So what about dietary cholesterol? For decades, eggs and shrimp were demonized. But for most people, they only modestly affect blood cholesterol. The real culprits are saturated fats, trans fats, and severe genetic conditions such as familial hypercholesterolemia. So yes, enjoy your eggs, just watch what they're cooked in. Butter and bacon fat can change the whole equation. That's the paradox in a nutshell. Cholesterol is indispensable, but misplaced cholesterol fuels the world's leading killer, atherosclerosis. How is cholesterol carried and measured? In the body, cholesterol exists in 2 main forms. Free cholesterol, sitting in cell membranes ready to be used. Cholesterol esters. This is cholesterol linked to a fatty acid, the storage and transport form inside lipoproteins. So when you check a standard lipid panel, what you're really seeing is the cholesterol cargo inside these lipoproteins reported in milligram per deciliter. Now here's the quick lab tour. 1. Total cholesterol. Everything lumped together, so it includes cholesterol in all the lipoproteins. Not very useful by itself. 2. LDL-C. Cholesterol mass inside low-density lipoprotein particles. This is usually calculated by a Friedewald equation. This equation is less reliable when the LDL is less than 70 mg per deciliter or triglyceride more than 400 mg per deciliter. The gold standard for measuring LDL-C is direct LDL-C by ultracentrifugation. This is more accurate but expensive and time-consuming. 3. HDL-C. This is the cholesterol in high-density lipoprotein particles. Typically identified as a good cholesterol, but raising it pharmacologically hasn't reduced cardiovascular risk so far. It's more of a marker than a target. 4. Non-HDL-C. This is often overlooked but a very powerful number to look at. It sums all atherogenic cholesterol in atherogenic lipoproteins such as LDL, VLDL, IDL, lipoprotein little a. This can be calculated by subtracting HDL from total cholesterol. So why the obsession with LDL-C? Because decades of evidence points the same way. High LDL particles cause atherosclerosis. The issue isn't that LDL exists, it's about how much is circulating. Now, in my opinion, LDL-C is only tip of the iceberg. It only estimates the cholesterol inside the LDL particles. ApoB gaining traction. They reflect the number of particles, not just their cargo. Despite their clear advantages, ApoB and non-HDL-C aren't yet routine primary targets, mostly because large trials historically used LDL-C as the endpoint. But newer evidence shows they are superior, especially for assessing residual risk in patients whose LDL-C is already low on statins. More on that in the future episodes. So let's talk about LDL-C in clinical practice. The guiding principle in lipidology is simple. Lower LDL-C for longer is better for reducing ASCVD risk. Therapeutic intensity should match patients' risk, preferences, and tolerance. Here's a quick framework of targets. I would say this is very simplified, but there's more nuance to this data. Very high risk. ASCVD plus additional risk enhancers. The goal LDL-C is less than 55 mg per deciliter. High risk, ASCVD or diabetes mellitus with risk factors. Goal LDL-C less than 70 mg per deciliter. Moderate risk, goal LDL-C less than 100 mg per deciliter. Low risk, lifestyle is a priority. You can find a summary of major United States guidelines and secondary causes in the free LipidCurious starter kit at www.lipidcurious.com. Now let's anchor this with a hypothetical case, and I would like to highlight high yield points which you can use in clinical practice starting today. Mr. R is a 58-year-old man with type 2 diabetes mellitus and a prior cardiac stent. His LDL-C started at 160 mg per deciliter. After high-intensity statin and ezetimibe therapy, it's now 72 mg per deciliter. Is 72 good enough, or do we aim lower? If you're thinking 70 mg per deciliter for LDL-C target is the traditional goal, you are right. But have you ever wondered why 70? Why not 64 or 76? It was basically a round number, a memorable cutoff that reflected the outcomes seen in the mid-2000s clinical trials. It was more of an interpretation of the data, not a physiologic threshold. But here's the nuance. With cardiovascular disease and diabetes, most guidelines would classify him as very high risk. So we want to target lower LDL-C, maybe less than 55 mg per deciliter. Now notice his LDL-C has dropped from 160 to 72. So more than 50% reduction from baseline. That's impressive, right? That's powerful because percent reduction often predicts outcomes better than absolute target, especially when the LDL-C starts very high. In very high-risk patients, you might want to have both the percentage drop and the absolute target to give us the confidence that we are truly reducing cardiovascular risk. We have all agreed that we need to go lower than 72. Despite the percentage reduction, we are wanting an absolute target for him as well because he's a very risk patient. What if we add PCSK9 inhibitor and his LDL-C falls to 22 mg per deciliter? Should we worry? Let's first define what is low LDL-C. There isn't a strict cutoff, but typically LDL-C less than 40 to 50 is considered low. LDL-C less than 20 to 30 is considered very low. Overall, evidence has been reassuring with low LDL-C. Physiologically, newborns and hunter-gatherers often live in the LDL-C 30 to 70 mg per deciliter range. Genetics-wise, people with PCSK9 loss of function mutations can live lifelong with their LDLs in the teens and have a lower heart disease risk. By contrast, other rare inherited conditions like A-beta lipoproteinemia or hypo-beta lipoproteinemia do cause severe complications. But those problems stem from the underlying disorder, not from the low LDL-C itself. Across landmark studies, statins such as PROVE-IT study, ezetimibe such as IMPROVE-IT study, and PCSK9 inhibitor evolocumab Fourier study, patients have achieved LDL less than 30 mg per deciliter, had fewer cardiovascular events with no new safety signals. Yes, Jupiter trial hinted at a slight increase in diabetes, and pooled evolocumab data suggested more cataracts below 25 mg per deciliter, but overall, the benefits have consistently outweighed the risks. Even in long-term follow-up such as Fourier open-label extension of 8 years, people with LDL-C less than 20 mg per deciliter kept benefiting without new red flags. Inclisiran's early data are showing the same reassuring pattern. In large PCSK9 inhibitor trials like Fourier and Odyssey trials, therapy was sometimes reduced or paused if LDL-C remained less than 15 mg per deciliter. But importantly, that was a trial safety protocol, not evidence that harm occurred at those levels. Physiology, genetics, and trials all point the same way. Lower LDL-C has been safe. Don't reflexively back off because LDL-C is very low. Instead, confirm by repeating or using direct LDL-C if available, reassess, and individualize based on the patient. Back to our case. How might we approach if, for real, Mr. R's LDL-C is confirmed to be very low on repeat checks? What do we do next? Now, this is an area with multiple opinions because there's no strict guideline or cutoff out there. Decisions often depend on clinician experience, their core therapeutic philosophy, and patient factors such as individual risk, preference, medication tolerance, cost, and risk of polypharmacy. I have observed experienced mentors who were comfortable leaving patients at very low LDL-C, and those patients often did well. At the same time, it's important to consider how well that applies to broader populations and to acknowledge the limited long-term safety data at very low LDL-C levels. One framework comes from the 2018 ACC statement. If LDL-C is less than 25 mg per deciliter on 2 consecutive checks while on a PCSK9 inhibitor, clinical judgment is recommended, since the long-term safety of such very low levels is still being studied. Within that teaching framework, some clinicians might choose to monitor Mr. R closely, while others may modestly de-escalate therapy, for example, by discontinuing ezetimibe or lowering the statin dose. To be clear, this is an educational reflection only. This is not medical advice. So here's the takeaway of this episode. Cholesterol is essential for life, but harmful when misplaced in atherogenic particles. 2. In clinical practice, both absolute LDL-C targets and percent reduction matters, especially in very high-risk patients. 3. Physiology, genetics, and clinical trials all are consistent, showing low LDL-C is better and safe, but decisions should always be individualized. Next episode is in 2 weeks. Then we're going to talk about lipoproteins and their journey. We're going to visit the exogenous and endogenous pathway. I'm really excited about that episode. It's one of my favorite topics. All right, folks. Thanks again for joining me on LipidCurious. If you found today helpful, I would love to hear your feedback. You can reach out to me at hello@lipidcurious.com. Be sure to subscribe or follow so you won't miss what's next. Until next time, stay curious and stay confident. Signing off, Dr. Pulipati.